Good evening, everybody. Thank you for joining us in tonight's Transplant Talk Live, Arrow, the Bone Marrow Transplant Foundation's webinar series. These webinars are an opportunity for us to delve deeper into a number of BMT, stem cell and CAR-T related topics, with tonight's webinar focusing on autologous BMT. I'm Angela. I'm the Patient Liaison Officer and Communications Officer with Arrow, and I'm joining you today from the traditional lands of the Wadawurrung people in the Geelong region. I have with me today our wonderful host, Yvonne Panek-Hudson. She is a clinical nurse practitioner in haematology at both Peter MacCallum Cancer Centre and the Royal Melbourne Hospital. Yvonne is also the co-host of the fabulous and very informative podcast, The Straight and Marrow. And Yvonne is also one of the directors at Arrow. She's joining us today from the traditional lands of the Wurundjeri people of the Kulin Nation in Naarm, Melbourne. Along with Yvonne, we are very fortunate to have two wonderful guests tonight. They are Taylor Bourchier. She is the Nurse Unit Manager of Ambulatory Cell Therapies at Peter MacCallum Cancer Centre, and Trish Joyce, who is a nurse practitioner in the Myeloma and Autograft Service at Peter MacCallum Cancer Centre, and they are both joining us also tonight from the traditional lands of the Wurundjeri people. I'll shortly hand over to Yvonne, who will be holding our Q&A session also at the end of tonight's webinar. We'll hold that once both our panellists have completed their presentations. So please feel free along all the way through tonight to pop any questions you have in the Q&A section. You can also pop these in the chat section if that's easier for you. We will be monitoring that throughout, and we will endeavour to try and answer all the questions at the end of the webinar. Please keep in mind that we're unable to answer any questions regarding your own health status, and we can only provide general advice and answers. So if you do have any questions that arise from tonight's webinar, we please ask you to consult with your treating healthcare teams about this. So without further ado, I would like to hand over to Yvonne, and she will introduce you further to our panellists. Thank you, Yvonne.
Thanks, Ange, and thanks again to Arrow, the Bone Marrow Transplant Foundation, for running these fabulous webinars. We hold them on a monthly basis, and we have such a great turnout, and I can see that we've already got 38 participants on tonight, and no doubt from all around Australia. I'm delighted to be hosting tonight's webinar on autologous bone marrow transplants, and to welcome two of my dear colleagues who are both experts in the field. So without further ado, I'll see you again at the end for the Q&A. So pop your questions in, and I'd like to welcome Taylor, who is going to give the first presentation. Taylor, feel free to share your slides. Thank you.
Thanks, Yvonne. Let's see if we can do this with no hiccups. All right, so everybody should hopefully be able to see the full slide deck and not all the notes. Thank you to Arrow for hosting this webinar and inviting me along to talk about everything to do with autologous stem cells and the role that apheresis plays. I am Taylor. I'm the Nurse Unit Manager at Ambulatory Cell Therapies at Peter Mac, which encompasses both our infusion centre and our apheresis unit. In terms of an overview of my presentation today, I'm just going to basically cover what are stem cells and why are we really interested in them. What are we using for mobilization and why is that important? Some of the methods, we'll explore apheresis a little bit further, and then next steps following on from apheresis, and then I'll hand over to my lovely counterpart Trish to cover everything else that I'm not capturing. So I suppose, what are stem cells and where do we find them? There are two of the most common questions that we get asked in apheresis and when we first see a patient, as well as their carers. It is the first thing is, why do you want my stem cells? So you might have heard them called many different things. We've got 3 different names, which I've highlighted just up here for for everybody. So we call them CD34 cells. We call them hematopoietic progenitor cells, and we also call them stem cells. They all mean the same thing. We're all looking at the same type of cell. We use them quite interchangeably, and I will use it very interchangeably throughout this presentation as well. In terms of what are stem cells, well, they're the building blocks of our body, and it's what our body is using to create blood cells that it needs to survive and function properly. Over the years that I've been doing apheresis, I've had a few different descriptions of what are stem cells coming from my patients. I've had very creative analogies comparing stem cells to babies, to seeds, and even building materials. And in all honesty, they're all quite correct because it is the foundation of a starting material of our body. They are the beginning, and like babies and seeds and building materials, we need the right conditions to be able to develop and grow, and they're essential for creating what our body needs. As we can see in the diagram on the left, just here, the process begins in the bone marrow, and that's the natural home of our stem cells, and it's where they exist in a higher concentration. However, this presents a bit of a challenge when it comes to collecting the stem cells, and while it's possible to collect stem cells directly from the bone marrow, it is an invasive procedure. So instead, we use a less invasive method by collecting the stem cells from blood, and to collect those, we need to use a process called mobilization. Mobilization is a process of encouraging the release of stem cells from the bone marrow into the bloodstream where we can collect them. Why do we need it? As we've previously said, our stem cells live in our bone marrow, and the mobilization helps them to move into the bloodstream where they can be collected more easily and safely without that invasive procedure of accessing our bone marrow. It's essential for ensuring that we have enough healthy stem cells to get your transplant as well. How do we mobilize? We've got 3 different main cohorts of methods, and that is by GCSF alone. So that is a growth stimulating factor. It starts at least 4 to 5 days before the planned day of apheresis. It is a subcutaneous injection that people do at home once to twice a day, depending on your dose. We've got a chemotherapy and GCSF regime. That is, chemotherapy is generally IV. It could also be a subcut, really depending on your clinician's preference there, as well as using GCSF. Now, the counting is really quite tricky and complex to really understand and interpret, but we generally give a dose of chemotherapy 10 to 14 days prior to the commencement of apheresis, with the GCSF starting 4 to 5 days before from the infusion of chemotherapy. Our last mechanism that we can use to mobilize a patient for a stem cell collection is the use of the GCSF and plerixafor. Now, this is very similar to just the GCSF alone process. We would use this if we thought that a patient would be quite difficult in order to collect stem cells, or if they had previously failed a collection of stem cells. Mobilization is a temporary measure, and any side effects that patients experience in this are quite mild and very manageable. Most commonly, people experience bone pain, and that is from the stimulation of your bone marrow to generate those stem cells. And it will be the only time that your treating team really celebrates your pain and discomfort in terms of bone pain. In preparation for apheresis, we do a variety of different things, and each centre will call it something different. It could be called pre-apheresis screening, it could be pre-transplant screening, or as my centre calls it, donor screening. It is an important step where we provide education about the procedure. We go through the consent to ensure that you are informed before undertaking a procedure. We review any of the current medications that you may be taking, as some of them may need to be paused or adjusted just before we put you on for an apheresis procedure. We also complete a lifestyle infectious disease questionnaire, and this is crucial not just for your safety, but to also ensure that anything that we collect from you is handled and stored appropriately. At this stage before apheresis, we'll also be performing a vein assessment, and this is to carry out the stem cell collection successfully. In order to do that, we need at least 2 good access points in your veins. So if your veins are suitable, we will use a rigid needle, which is not coming up in my pictures, just noticed. There is a rigid needle that we utilize, and the other needle that we use is a standard cannula, which many people may be familiar with from previous hospital stays or infusions of treatment. And they're put into your peripheral veins, into the arms. If we find that your veins are not suitable, like they're on the smaller side, or they're a little bit more difficult to get access to, and you require multiple attempts at getting blood tests done, etc., then we may need to look at getting you a central venous catheter, such as a permacath or a vascath, to make the procedure smoother and more comfortable and assist in making it a successful process. There we go. There's animations. So that's our peripheral needle just here. This is an example of a permacath. It is a tunneled line that goes in through the chest there. And then we have a vascath that goes in up on the side of the neck. So we've got a few different options there. And they're the devices that are compatible with apheresis procedures. What to expect during apheresis? So day 1, when you come and see us in our department, it'll begin with blood tests. We need to do those blood tests and await those results to ensure that all of the levels are at an appropriate threshold in order to enable testing, but also to enable us to be successful in our procedure. So what I'm talking about there is the requirement of checking your white cell count. That number needs to be 1 or higher in order for our scientists to go ahead and check for CD34 or stem cell count. In the event that your white cells are not meeting that threshold, we would look at giving you additional medication and bringing you back the following day to continue monitoring. If your white cell was to be 1 or higher, we would actually run a CD34 count, and in that we need to at least see a CD34 count of 10 or higher in order to put you onto the apheresis machine and be successful in yielding stem cells through that process. Very similar to if you were to meet that threshold of 10, we would bring you back the next day and continue monitoring, adjust some medications, maybe give you something extra, but we'll be covering that a little bit later at the end of this presentation. So these results of your white cell count and your CD34 really help us to determine whether we can proceed with any collections and what's going on for you at a really cellular level in terms of your bloods. And they're very critical that we review these before we start apheresis. We don't want to be putting a patient onto a machine unnecessarily and unsuccessfully. We want to make sure that everyone's in the best picture going into this type of process. Apheresis procedures generally go for 3 to 5 hours per session over 1 to 3 sessions. You will probably be booked in for 3 sessions straight off the bat. You might not need them. You might only need the 1, but we want to make sure that we've got that time allotted to ensure that we can be successful in this process. As with anything, some people can experience some side effects during apheresis and also immediately following apheresis. The good thing is that most of these are mild and very easily managed and corrected in real time. A lot of people do experience a symptom of tingling around their mouth and in their lips and also in their fingertips. This is a common side effect for everybody undergoing apheresis. And it's directly related to the anti-clotting solution that we use and is a symptom of low calcium levels. So in order for us to correct that, we start giving you either some calcium tablets to chew on, or we start an infusion of calcium replacement. Within a few minutes, those symptoms are all resolved and we can continue on with what we were doing in terms of the apheresis procedure. Some people also experience lightheadedness and feel quite fatigued after apheresis. Throughout the whole process, we are monitoring you really closely to ensure that you're comfortable and that everything is safe and everything is all above board. The tip I would say is what to expect during apheresis is that once the procedure has commenced, that's the fun part. That's the only interesting part, is watching us set up a machine and get you all set up for the day and comfortable. But once the procedure is actually running, it actually gets really boring when you've got to sit there and just wait for this process to be done after 3 to 4 hours. So we encourage our patients to bring books, laptops, headphones, and definitely a companion that you like to talk to, because you've got them or your nurse to talk to for the whole session, which can make it very difficult if you don't like the person talking. We've got, what is apheresis? So to take it really back to the beginning, apheresis is a term that we use, and it means to take away, the removal, the separation. So we can see how that ties in really nicely with what we are trying to do. We're trying to remove and separate and take away stem cells from your blood in order to be able to give you a treatment later on. In order to do this, this is achieved by using a device called the Spectra Optia for our department. There are other devices available. And it separates the whole blood that we take from patients and puts it through our tubing set down into a centrifuge, which is down in this part of our machine here, and it spins out the blood. And we can see it in our tubes here. This is our whole blood coming into a machine. It's getting spun around, and we can see here that it's starting to separate with that nice color gradient there. What we end up seeing with this machine is that really defined separation of the layers of your blood, and that's by their weight. We use apheresis for a lot of different procedures, not just stem cell collections. We use it for blood product collections, like platelet collections. We also use it for therapeutic treatments, where we are removing unhealthy or excess blood cells and replace them with donated cells to treat various conditions. We also do lymphocyte collections, which is quite similar in principle to a stem cell collection. We're looking for specific cells in this middle layer of your blood. So how do we extract these stem cells? So as I was saying, we can look down into our centrifuge of these Optia devices, and this picture here on the left is a great picture of that separation happening in real time for a patient. We can really see the 3 defined layers here of our plasma, as we've got here on the blood tube. There is a very light grey layer just on top of the red, and that is our buffy coat there. And then we've got our really heavy cells, which is all that dark space down on the bottom here. So that's showing us that we can separate out our cells, and it is allowing us to be able to extract them. So we can also see in that far left picture that there's 3 tubes coming out of the top. We've got them here. We can see the clear tube. This is and we've got a yellow tube and we have a red. So our stem cells in this process are actually coming out of that clear line. They come up out of here and they come up into this very small line here. And this goes off into a sterile collection bag where your stem cells are collected into for the whole procedure. We also have our yellow line here. This is collecting out all of the yellow plasma. So we like to color match in apheresis as well. So yellow to yellow, our plasma is coming up and out, and we can see the yellow tube here, and this is going straight back to you. Our last one here is our red cells. So all of your red blood cells is coming straight back up and going straight back to you. As you can see, it's nice, bright and red here. The only thing we're taking away in this whole process in this particular procedure is your stem cells. There's no volume loss. There's no other blood cells being lost or compromised. If anything, you're actually receiving a lot more hydration than you might achieve in a day. You receive at least 1 litre of fluid throughout the whole process. And during this process, you don't need to go under anaesthetic or anything. You are awake, you're in a treatment chair or in a bed for the whole procedure. And you can do different activities of reading, watching a movie, chatting with your friend or chatting with the nurse. Or you can even nap for the 5 hours that you've got connected to a machine. There will be an apheresis nurse with you for the majority of that procedure, just to ensure that 1, the machine is absolutely running appropriately, and 2, just to ensure that you're tolerating the process and procedure adequately as well, and that everything is safe. So now that we know how we're collecting these stem cells, we can either be successful or unsuccessful in the collection of our stem cells. So at the end of a procedure, we like to take a sample out of a product bag that looks like this. This is what your stem cells look like once they get collected. We take a sample as nurses or scientists of about 1 ml, no more than that, to determine how many millions of cells we've actually put into this bag. That will determine if you need to come back for additional days of collection, if we were successful, if we were unsuccessful. We do have 2 targets that we like to work towards, and this is decided by your treating team, and it's really based upon your disease and condition and what treatment method they want to go for. We see targets of 3 to 5 million, and we see targets of 6 to 10 million. That's all very achievable, and it's why that mobilization process is really key to being successful here. In a successful apheresis procedure, you will have mobilized and you will have triggered the process of being able to have an apheresis procedure, and we will have achieved the collection target of however many millions of cells in the 1 to 3 apheresis sessions that we had scheduled. In an unsuccessful apheresis procedure, sometimes, even with mobilization and the process of apheresis, we may not be able to get enough stem cells. If this happens, sometimes we need to halt the apheresis procedures, or sometimes we proceed on to try and get what we can and make the most of the situation. We generally go back at the end of apheresis, we review medications, and we look at doing a mobilization strategy that was different than the first attempt, to ensure that we're trying to really look at all of our options to be able to get these stem cells from you. And it's important to remember here that every patient is very different. And whilst we all have blocked out this time, and we all have allocated particular targets and processes for diseases, we might not be able to achieve what we want to. So we need to really refocus and tailor this experience to each individual patient. So we try the process to the best of our ability. If we're unsuccessful, then we'll go back and try again in a different way to try and be more successful next time. So what happens after apheresis? Where does this bag of cells actually go? For us, it goes up to our cryopreservation scientists, who will do some wonderful magic and freeze down these lovely cells. So they'll receive a cell bag that looks very similar to this, which is all mixed up from that first picture I showed. They will do their science magic and separate out all of the cells for us, and then they will slowly freeze them down to be able to store them into the liquid nitrogen. Now, the storage of these cells and the length of that is very dependent on how quickly people are going to transplants, or if we're collecting for things way further in the future. and the cells will remain in storage until the clinical team decides to proceed with the transplant. So this is what the bag of cells looks like once it is fully frozen. So it looks quite different to what we collected and what we handed off to our scientists. So it's just acknowledging that there is a bit of a difference there. And that's it for me. I'm going to hand on over to Trish.
Thanks, Taylor. That was absolutely fantastic. And I'm sure we're going to have plenty of questions at the end of the presentations, but thank you very much. And your visuals were really great. Trish, I'd like to welcome you to give your presentation and look forward to hearing it and also receiving some questions. Thanks very much, Trish.
Thanks, Yvonne. And thanks to Arrow for the opportunity to share this evening with you. It's lovely to be here, and thank you so much for setting the scene, Taylor. That was a wonderfully comprehensive and succinct presentation. So without further ado, I'm going to take you the next step, which is talking about the transplant itself. And so I'm just going to have to give me a moment. Here we go. Okay, so essentially, Taylor has very nicely pointed out how we collect the stem cells, which is a fundamental part of the autologous transplant. And the timing of when we collect a person's stem cells will be different for every person. So my job for the next 15 minutes or so is to talk about the transplant itself, preparing for the transplant, putting the stem cells back in, and then life during the, how you might feel during the inpatient period when the transplant is being undertaken. And then we'll talk a little bit about follow-up after you leave the ward and what your recovery is like and things to watch out for. I just wanted to, set the scene a little bit first. And it's always good to go back to the drawing board and remind ourselves, look, why are we doing the transplant? And particularly for the person going through it, it's important to know the bigger picture, because there'll be some tough days as you go through this treatment, but you got to keep reminding yourself, okay, my medical team said this was an important treatment. And the reason why we offer this treatment to people is with a curative intent. That's one reason. And the second reason is in some people, particularly in multiple myeloma, what we want to do is deepen that remission or deepen that response, because we know that the deepest response in myeloma translates into the longest period where the myeloma will remain in remission and where the person will, enjoy a good quality of life. So those are probably the two main objectives of why we recommend this treatment for patients. And so the choice of chemotherapy that we give when we're preparing or conditioning somebody for a transplant will depend on the underlying blood cancer. And so multiple myeloma worldwide is the most common indication of why an autologous stem cell transplant is recommended. And it's part of standard of care for patients under the age of 70. That doesn't mean that people over the age of 70 cannot have an autologous transplant, and far from that. Quite a lot of our patients here at Peter Mac, we do it for our patients over 70. But in that patient group, we would want to make, really check everything, make sure that the person's physiology and fitness for a transplant is critical and is assessed properly. So the oldest person we've done here for an autologous stem cell transplant, I think, was 78. And that person had multiple myeloma. So it's important to remember that there are different diseases we treat with autologous stem cell transplantation, not just myeloma, which is the most common reason. We also do relapsed aggressive lymphoma or relapsed diffuse large B-cell lymphoma. We sometimes do it for follicular lymphoma that has relapsed, which is a variant of lymphoma as well. We also do it for some testicular cancers. and also relapsed Hodgkin lymphoma. And in the lymphoma group, the main objective is to cure the relapse disease. In multiple myeloma, the focus is different. It's trying to attain that very deep response, because we know in myeloma at this point in time, we can't cure it, but we have really good treatments to deepen that response and to get the patient into a long remission. So the type of chemotherapy drugs that the person will get will depend on prior chemotherapy exposure and how sensitive their disease has responded to previous chemos. So, and that's a very important point, because we want the person to have had a good response to their chemotherapy. Apologies, that's just an overhead announcement. So we want the person to have had a good response to that salvage chemotherapy that's being initiated as part of the relapse of their disease before we take them into a transplant. So that's all in the, in the minds of the transplant physician when they're talking to you about getting you ready for a stem cell transplant. So I think the most important bit in anybody's transplant is getting prepared. And I think what's really important for anybody that's been offered and recommended a stem cell transplant, information is critical. And that can be empowering. And you're in a situation where often you might feel that a lot of your control is being ripped away from you. So there are things that you can control in this, and allowing you to do that can often be, can make you feel better about what's going on. So I think garnering as much information as you can, seeking that out from your medical team, your specialist nurse, trying to, attending groups like this, getting your medical team to set you up with a couple of buddies. So by that, I mean a patient that's been through a stem cell transplant can be really good to connect with. You hear all of the information from doctors and nurses and the apheresis specialist nurses, but it's nice and really valuable to talk to a patient that's undergone this treatment. And I always think that they will have really great pearls of wisdom that often we don't really pick up along the way. So I think that can be all really a good part of your preparation. I want to spend a bit of time talking about exercise, because exercise is a fundamental part of your preparation. As healthcare professionals, we all now know that we've got guidelines telling us that exercise has many benefits for patients going through cancer treatment. And I think talking to your medical team, seeing a physiotherapist, exercise physiologist, and asking them, for an individual assessment and tailoring an exercise plan that's right for you. And everybody's going to be different. So I think that tailorization is really important based on what you can do. So for example, somebody with newly diagnosed myeloma that has been offered a stem cell transplant, which often will come up in that first 1 to 2 months of your treatment, it will be starting to talk about what a transplant is. That's when I think it would be really valuable getting, talking about the role of exercise. And here we at Peter Mac, we've got what we call a prehabilitation program. And one of our doctors, I thought it was quite nice, but he said, imagine your patient is trying to get ready for the Olympics. This is what we're trying to do in getting the person to be in the best possible shape they can be in for their transplant. So as part of that prehab program, we've got an exercise physiologist, a nutritionist, and a psychologist, because we understand that it's not just physically challenging, but it's also mentally challenging. So I think if you can set yourself up and arm yourself with a lot of these kind of strategies and gain the benefit of seeing these specialists, as well as your medical team, it can be really, really valuable. And it's not just about improving your fitness. These programs are really good as well at strengthening your cardiovascular system, improving your lung function. And also there's evidence to suggest that exercise can actually boost your immunity. And I think it sets a really great foundation for your tolerance and trying to reduce the risk of side effects during the transplant. And more importantly, what you learn about exercise in the preparation will hold you really in good stead as well after your transplant. So all the way through the transplant treatment trajectory, exercise plays a very, very important role. And I think this gives you, control as well, and something that you can do during your transplant. The other thing, as part of preparing for a transplant, it's very routine that you'll be asked to check your heart function, your lung function, your kidney function. Again, because we're about to give high dose or intensive chemotherapy, and we want to make sure your heart, your lungs, your kidneys are all working well and can cope with the chemotherapy. Also, I always say to patients, it's not one size fits everybody. Sure, we've got protocols and treatment regimes that are different for a patient with myeloma to a patient with relapsed diffuse large B-cell lymphoma. But I think it's important for you to remember that all of these treatment regimes are modified based on the person's general health, such as their kidney function, how well their heart is working, what their kidneys are doing. And there may be additional testing that your medical team may ask you to get done as well. For example, you might have to have a liver ultrasound if there were some concerns around your liver function. If somebody developed ringing in the ears, for example, related to treatment, we might want to get a hearing assessment done. So I think this feedback from my patients, working with my patients, preparing for a transplant, is they find that this part reassuring. It means they're going into the transplant not leaving any stone unturned, and we know we're ready and to get started with the high dose chemo. Okay, so this slide here just talks about the different high dose chemotherapy regimes. And so I alluded to before, depending on what the underlying disease that we're treating, there'll be different chemotherapy protocols. But the transplant essentially is the administration of high dose chemotherapy that knocks out the bone marrow significantly, to the point that if we didn't put the stem cells back in, the person would have significant bone marrow depression for many, many months, with the consequence of lots and lots of health issues. So by re-infusing the stem cells, it reduces down that obligatory period of bone marrow suppression from months to about 7 or 8 days. So you can see here with melphalan is a common drug. It's the gold standard that we use in multiple myeloma. And so for that, we put the stems, we give them the chemo on day -1, stem cells are in on day 0, and then we would expect to see that profound bone marrow suppression from about day +5, so 5 days after day 0 to day 11. With lymphomas, it's a little bit different. The treatment regimes are a little bit more involved and often can run usually for about anything from 4 to 6 days. Beam is a common one we use, and that starts at day -6. And each chemotherapy protocol is chosen based on lots of evidence around it. For example, there's a particular type of lymphoma called primary CNS lymphoma. It's where the patient presents with the lymphoma only in the central nervous system. And so doing an autologous stem cell transplant to consolidate that response after they've finished their 5 to 6 cycles of primary therapy is a really good treatment to try and cure this type of lymphoma. And one of the drugs that we like to use is a drug called Thiatipa. So this starts at day -6, and stem cells re-infuse at day 0, and then you've got the period where you're I don't think I can go back, and I've skipped one, so apologies. Let me try again. There we go. Yeah. So yeah, this last one is one that we typically use for testicular cancers. So that just gives you a flavor of what your medical team is thinking about when they're getting you prepared and the chemotherapy protocol. I guess side effects during the chemotherapy, when you get admitted, there's a multitude of side effects that people would be counseled on to expect. But here is just a snapshot, but particularly the side effects are directly related to the conditioning chemotherapy. So nausea can happen, vomiting, loss of appetite, and this is directly related to the chemotherapy drugs. Fluid retention, plus or minus weight gain and weight loss. Some people can experience hypersensitivity reactions to the chemotherapy. It's a very common reaction that we get with one of the drugs called carmustine. Again, your treating team will walk you through that. It doesn't mean that you're allergic to the drug. Any drug that we take into our body can sometimes have a hypersensitivity reaction in the person, and there's ways to manage that. Typically, bowel disruption, fatigue, skin rashes are very common, disrupted sleep because you're in a hospital. We're waking you up in the middle of the night. We're doing your blood test early in the morning. So that can be a tricky time as well. So I think tips for you is about, telling us how you're feeling. We're not mind readers. So you need to let us, your treating team, know on the ward, hey, this isn't working for me. I'm still nauseated. Any of your, concerns, you need to let us know. I think it's important as well to bring in some of your favorite snacks to snack on. We'll have a dietitian. That's a very common resource that all patients have access to in the preparation phase of the transplant and as they go through their transplant, and also follow up afterwards, because nutritional intake is a very, very important thing during your transplant. It's important to keep a daily routine, and people often say, but how can I keep a daily routine when I'm in hospital? But it's a critical part of helping you to cope often with that, tough time, particularly in the first week. People get a bit of cabin fever. So I think having a think about that, and preparing and thinking about, okay, how am I going to fill my days in, particularly if you want to, in that first week, generally patients are well. It's quite prescripted in what we're doing. We're administering the chemo, putting back in the stem cells, and it may take 2 or 3 or 4 days for side effects to kick in. So having a think about what you might fill your days in. Look, some of our patients bring in some fold-up tables, bring in their laptop, try and do a little bit of work from their room, download lots of podcasts, bring music in, people bring in things to decorate their rooms. This is all really, it's helpful, when you're in, because, going away, because often, typically a patient with myeloma coming in for a stem cell transplant is an inpatient for about 14 to 16 days. And then with the lymphoma group, it's a little bit longer, because as I showed you, their regimes go for around about an average of 6 days. So typically they're an inpatient for around about 3 weeks. This is the reinfusion of the stem cells, day 0. It's a very special day. A lot of patients describe it as a complete anticlimax. They should be brass bands playing and, nothing happens, and the stem cells are gone in very nicely without, a flutter. So it's a very straightforward procedure. It's done through one of those lines that Taylor showed you in her presentation. So it can be a permacath line or a PICC line. So every patient coming in for a transplant will have some form of line in, and that line will be discussed with you, and the right one will be chosen based on your concerns and your thoughts and what you feel would work well for you. Some people choose the permacath line because it means that that line can go in right at the start and can remain in place until we've completely finished the transplant. So when I say right at the start, just before we go in to collect the stem cells, Then you might have another cycle of salvage chemotherapy and then the transplant. Some people prefer to put in a PICC line, which just goes in on the day of admission. And look, both lines work very, very well for the transplant. So yeah, you'll be having that discussion with your treatment team when that time comes. The reinfusion of the stem cells takes about 60 minutes. When the cells get stored and the cryopreservation scientist team are working on that, they add a preservative agent called DMSO to your product, and that's to maintain the cells during that freezing period. When we thaw the cells, that can create a very distinct sweet odor that the patient will breathe out. So it's not so much that the patient is aware of it, but people that come to visit, because it can usually linger around for about 3 or 4 hours after the infusion. The preservative agent can give you some mild sort of facial flushing and a tickle in the throat, but it's pretty a straightforward procedure. And it's a great day because it means your stem cells are coming home. And you know, it means that you've finished your chemotherapy, and now we've just got to support you through the next couple of weeks until your stem cells are fully grown and functioning and mature blood cells. So you will hear the medical team talk about this thing called the nadir. And the nadir in your cycle is when your white cell count, or when that bone marrow suppression period happens. It's when the blood counts, particularly the white blood cells and especially the neutrophils, and the neutrophils are the body's first responders to infection. They are soldiers, and they go to 0. And typically that happens from around about day 4 to day 10. Can be a little bit earlier, can extend a little bit later. But that's the typical period where you're going to experience the peak of the side effects associated with the chemotherapy. So if I'm preparing a patient for a transplant, I always talk about there are 2 main side effects from undergoing an autologous stem cell transplant. The first is infection, and the second is mucositis. So infection, and the reason is the neutrophil count is 0, the body's first responders, and also your normal protective barriers that keep the bad guys out are disrupted. And about 97 to 100% of patients undergoing an autologous stem cell transplant will experience infection. So be prepared that that will happen. We manage that very effectively. As a nurse working in hematology in the transplant unit here, that's our bread and butter. This is a very, very, you know, streamlined approach in people where we think have an infection and we start some antibiotics. The second big side effect is mucositis. And mucositis is a result of the chemotherapy that damages the rapidly dividing cells. So it's kind of, if you like, the collateral damage to the high dose chemotherapy. And I'll talk about that in a little while. But all of these things are directly related to the high dose chemotherapy, and then the need for blood products. So infection and mucositis and bone marrow suppression, and the body's normal protective barriers are disrupted. So out of all those things come the various side effects. And so infection is number 1, and that's, you know, particularly while we're waiting for this engraftment. And engraftment is just a fancy word, waiting for those stem cells to grow up into functioning adult blood cells. And that period takes about 7 days. And usually it can vary, but usually it's day 10 to day 4. It's around about day 10 to day 12 when we will see that happening. So risk of infection is important. It's most commonly within the patient themselves, the person. And the reason for that is that our normal barriers to protect the body are impaired. For example, the skin, you have a lining, it's a little window, the bugs can get in, the gastrointestinal tract can get a little bit impaired, and bugs that normally live in our bowel can seep in into your bloodstream when those barriers are down. So that's one of the main reasons why people get infection. Around about day 10 to day 14, when those blood cells are maturing, you can get this thing called engraftment syndrome, which can sometimes mimic infection. It's when those lovely stem cells have matured and there's an army of them bursting through, and sometimes they can secrete these little proteins that can cause an immune response, and you might get a fever at that point, but it's very manageable with steroids and some fluids, and sometimes we start antibiotics at that point if needed. Mucositis is the second most important side effect, and that's a direct result from the chemotherapy. So it happens all the way down your gastrointestinal tract, affecting your mouth in the form of dry mouth, sometimes mouth ulcers, taste changes, reflux, nausea can happen, and diarrhea is very, very common. Reduced food intake, abdominal bloating, discomfort. It's difficult to predict exactly. Everybody gets it. Some people get a little bit more than others, and we're not really, we don't really understand why that is. There's a couple of things that might give us. So, for example, if somebody had prior radiotherapy to their neck and sort of the floor of their mouth, they might have an increased risk of mucositis. Similarly, if they had radiotherapy to their abdomen, there might be a flare-up of mucositis in the gut. But we really don't have a good handle as to why some people get more of that mucositis than others. Sometimes it can be quite significant, particularly when it affects your gut. And in that situation, a good thing to do is to rest the gut, feed intravenously, so a liquid diet through your PICC line and your permacath line, something to rest your gut to allow it to heal. And sometimes we will do a CT scan as well at that time, just to make sure that we're not missing any little, abscesses or pockets of infection that might need a change of your antibiotics. So once you're ready to go home, that's obviously, a really great time, and everybody's really excited to leave the ward. The criteria for discharge is not so much that your blood counts have to be back up to normal levels, as we're happy if your neutrophil count is rising and it's above 0.5, we would be happy for you to be discharged. But it's more about how you're feeling yourself. Are you able to keep your fluids down? Are you eating small amounts? Can you go home with taking your medication? Because a lot of our patients will be on more drugs and medications than when they came in with, and that's okay. And over time, we'll be weaning those off. So a couple of things I just wanted to highlight, that it's very normal to have this overwhelming fatigue, particularly in that first couple of weeks after your discharge, and that's nothing's wrong, and with time that will improve. Residual side effects from the mucositis will still be present when you do go home and may take some time to resolve, and that's why you have close contact back with your transplant center, regular reviews, so you can report on that. Sleep can be disturbed. What we recommend is slowly and gradually increasing your activity and your exercise at home, and avoiding this boom bust cycle. I think that's really important, because a lot of patients, when they get out of hospital, are just so liberated to be home. They put on their walking shoes and go for a big long walk, and then are exhausted for the next 5 to 7 days. So it's important to take it easy, to be kind to yourself. But the tips I've put on there is just setting yourself some small goals. It's normal to have some up and down days. Your fluids are really important, keeping up your anti-nausea drugs, and staying in touch with your treating center if you have concerns. I'm close to finishing, but I just wanted to talk about infection, because your immune system is still vulnerable, and that's because of delayed, you've lost your immunity because of the treatment, and your immune recovery is continuing, but it's going to take some time. So you are vulnerable to vaccine preventable infections. And there are some viruses, for example, chickenpox, that can be reactivated. So you'll be on some medication to help reduce the risk of those viruses reactivating for some time after the transplant. I think some infection prevention strategies when you do go home, especially in the first few weeks, and we've all learned this from COVID, is mask wearing. I think promptly testing if you've got any flu-like symptoms. There's kits now that you can get to test for the whole influenza, RSV, and COVID. And the promptness of doing that then alerts us to if you have a viral infection. And there's a number of antiviral medications that we can start, especially for COVID and for influenza. And I think your vaccines, very, very important, and also your household contacts. Particularly, we're heading into winter now, so influenza is really important. Many of you will be thinking about traveling in the future, and I think that's a really great plan to look forward to, especially after going through, your transplant. And important to discuss it with your transplant team, because there is quite a detailed comprehensive revaccination program that we do recommend to our patients after a stem cell transplant, which usually starts about 6 months. So that's important, but also checking in with your team, letting them know your plans, and then seeing your GP to ensure that other additional vaccines that may be required for your travel destinations is done. I think that's something very important, and many of our patients after autologous transplantation are traveling. Preventative healthcare is really important as well. We know that patients after chemotherapy, not just autologous stem cell transplantation, are at risk of developing secondary cancers. So most transplant centers have a really good follow-up assessment clinic in place to counsel you about what you need to do to prevent those and to ensure that you're doing them. There's a slightly increased risk of cardiovascular disease. And again, meeting with your team, they'll be discussing that with you and working through some modifiable risks that you might need to do, and we would recommend to reduce that. We talked about risk of infection, and as we are all getting older, we're of course at risk from age-related diseases. So follow-up care after your stem cell transplant is really important. And these are just some of the recommended cancer screenings that is recommended, such as breast screen, doing your second yearly colorectal screen, prostate cancer blood screening, cervical cancer screening, and then your annual skin checks. In terms of, cardiovascular disease, it's exercise, diet, not smoking, keeping your alcohol intake to a minimum, and then making sure your vaccinations are up to date, making sure you're addressing your bone health, which is really important. And then, any, new symptoms or residual side effects that you feel aren't getting better, because it's a long process recovering from a stem cell transplant. And some people feel fully recovered and back to normal in 3 months. For other people, it might take 6 to 9 to 12 months. So it's very, very variable. So it's important that when you meet with your transplant team, you let them know what's not working for you, what you feel you need some help with. Is it exercise? Is it management of your mental health? Because going through transplant is an arduous process physically, but also mentally, like I alluded to at the start. And there's really good supports out there for people, to get you through and support your mental health as well. I think that's really critical. And of course, your sexual health as well. It's really important that, we address that. And if you have concerns, a reduction, it's very important. It's very common for patients going through intensive treatment like this to have reduced sexual libido and maybe other additional sort of sexual health issues. Menopausal symptoms are pretty common. So these can be addressed at your follow-up clinic, and they're really, really important, because the end goal is to get you cured of your underlying lymphoma, or in a deep remission, but also optimizing your quality of life to be able to manage the issues that come up along the way. There's a plethora of supports out there and resources. These are just a couple. The Leukemia Foundation has a wonderful booklet on autologous stem cell transplantation. So does the Myeloma Australia has one specifically for myeloma patients. And I didn't mention it, but I've put up there, we've got a home-based stem cell transplant program as well that we offer to our myeloma patients. And they're just a snapshot of some of the resources that you can tap into to gain some further information about your transplant and to ensure you're prepared for the procedure. So on that note, I might stop and hand over to you, Yvonne.
Thank you, Trish, and thank you, Taylor. I mean, they were such comprehensive presentations that covered the entire process of autologous stem cell transplantation. There are a couple of questions, and Ange, with your permission, we'll just go slightly over time. People are welcome to drop off if you need to, but I'd really like to ask these really important questions. So the first one is from Tarina, and I'm going to ask you to answer this question, Taylor, please. What is the difference between a stem cell transplant and DLI?
Oh, it's such a good question.
Isn't it?
Slightly different target cells at the end game. So stem cell transplant is those CD34 cells. So they have the little CD34 marker on them, whereas DLI, we're looking for a CD3 marker. So very similar, much the same space of what we're looking for when we do collect stem cells, but just a different target cell. So it's just got a different check flag on it for our scientists to extract it and then give you that in a bag for an infusion. And it's to promote a more immune response rather than giving you stem cells, because you don't need stem cells. You need that immune response.
Thanks, Taylor. Tarina also made a comment that the antifreeze, so the DMSO, makes the infusion taste terrible too. And I think Trish might have mentioned that in her presentation. So the second question, Trish, I'm going to ask you to answer, and this is from Rachel. And Rachel asks, how soon post-transplant can a patient receive vaccinations, e.g. flu or COVID? Thanks, Rachel, for your question as well.
Yeah, thanks, Rachel. That's a really great question. So we would recommend, and what's generally recommended is, if we're in the flu season, I would recommend the first influenza vaccination. There's good evidence now to support 2 doses of influenza vaccination in your first year after transplant. So what we would recommend, Rachel, is around about day 28 or afterwards, get your first dose, and then 4 to 6 weeks later, get a second dose. We're right in just about to start the winter season. So if somebody's coming out of their transplant now, that would be really important. For all subsequent years, a yearly flu vaccine. There's no evidence to support 2 doses for subsequent years thereafter. COVID is ubiquitous and is not going away. So getting a COVID revaccination is important as well. ATAGI recommends at 3 months having a booster, and then depending on what you're at, where you are at, we would recommend probably a booster around about 3 months later. And then thereafter would be yearly for people over the age of 60, and particularly the people over the age of 75 every 6 months. And then the post-transplant vaccinations, which are all of your childhood revaccinations, start around about 6 months after transplant. Does that answer the question?
It absolutely does. And it actually answers a question from Alex as well, who asked about the full revaccination program, Trish. So the question was around, is it wise to have the full childhood revaccination program?
Oh, we recommend it, absolutely. look, we haven't got access to very good, robust blood test measurements to measure how a person has retained their immunity to tetanus, to polio, to meningococcal disease. So we work on the premise that it's very likely that a person that's had a transplant has reduced immunity and that some of that protection level has gone. It may not be gone completely, but it's all about the person's health, keeping them well, keeping them protected from these, infection, vaccine preventable diseases. So I would definitely recommend it. And it's about keeping yourself well and healthy and knowing you've got that protection back in you, particularly as you go on to live your life and travel overseas. It's really important.
And Trish, there is a difference in time as to when you introduce inactivated vaccines and live vaccines after transplant.
Yeah, that's true, Yvonne. So you want to have and ensure that you've got good immune reconstitution. Giving a live vaccine early on in the recovery is not recommended because of the risk of side effects and becoming unwell from a live vaccine. So generally the recommendation is to wait for 2 years after you transplant for the live attenuated vaccines.
Yes.
Which there aren't too many out there, but yeah.
Yeah, and there's fewer and fewer, which is great for our patients. But be guided by your medical teams, because your transplant team will be all over this information. Well, that brings us to the end of our Q&A and the presentations from the wonderful Trish and the wonderful Taylor. Thank you so much, ladies. The information you've given to all of us tonight has just been outstanding. And I'm going to say goodbye and hand you back over to Ange. Thanks, Ange.
Thank you, and thanks so much, Trish and Taylor. That was absolutely fantastic. I can't believe how much we learn from these webinars, and I get quite engrossed in everything and I do lose track of time. But that was absolutely fantastic, and we're very appreciative of you coming on. To our audience, thank you all for coming on and watching tonight. There will be a recording of the webinar and you will receive a link via your email once it has been finalised and uploaded. And also, if you can stick around, we do have a short survey at the end of this webinar, and we really do value your feedback with these with this process. It really does help us improve and add anything that our audience would like to see. We do take everything on board, so please stick around and fill that survey out if you can. And also, if you do have any questions that arise from this webinar with regard to your own health, please do contact your treating healthcare team, as we said earlier. If you have any questions for us at Arrow, please don't hesitate to send us an email. You can reach us at www.arrow.org.au, and you will find contact details there. So thanks again for joining us. Sorry we ran over time a little bit, but it was fabulous information and well worth sticking around for. So look out for our next webinar, which will be at the end of June. Okay, thank you all.
Thanks. Good night.
Thank
Good
you.
night.
Bye.
Bye.